name is Haytham Kafrani. I'm one of the trauma surgeons at Mass General Hospital and Harvard Medical School and the director of COMPASS, the Center for Outcomes and Patient Safety in Surgery. And I would like to thank each one of you for joining what promises to be a very exciting webinar, and it's going to be interactive. So please feel free to add your Q&A as we go, and I will try my best to go through all the questions that you guys have. I would also like to remind you that for all the attendees, we're going to do a random sampling of 35 of you to receive a free copy, a Kindle copy of the book by Dr. Lee, which I will introduce in a minute. So it does really give me a special pleasure to introduce Dr. Vivian Lee to all of you today to give our quarterly webinar at COMPASS. Dr. Lee is really a very well-known figure in the quality and safety world. She is the president of Health Platforms at Verily Life Sciences, an Alphabet Google company focused on life sciences and healthcare. She is a physician and a healthcare executive. She also served as a senior lecturer at Harvard Medical School. Before joining Verily, Dr. Lee served as the Dean of Medical School and the CEO of the University of Utah Healthcare, an integrated health system with a budget of nearly $4 billion, including a 1,400-member physician group and a health insurance plan. During her tenure, she led the University of Utah to recognition of its healthcare delivery system innovations that enable higher quality at lower costs and higher patient satisfaction, as well as superior financial performance. She has been elected to the National Academy of Medicine, has more than 200 peer-reviewed publications. She serves on the board of directors of the Commonwealth Fund, the board of trustees of the Boston Children's Hospital, and is also the director on the board of Zions Bank Corporation, a publicly traded company. She is also the author of a new book, which I encourage you all to read. It's a fascinating book. It's called The Long Fix: Solving America's Healthcare Crises with Strategies That Work for Everyone. Dr. Lee, please take it from here.
Thank you very much, Haytham. Really, it's a real honor to be with you all today. And I really thank you for the invitation, and thank you also for sharing copies of my book. That's very kind of you. So let me just go ahead and share my screen. And I recognize that I'm not in present mode, but at least in this way, I can still see some of you on my screen. So I hope it's still visible to you clearly enough. So today I'm going to talk about quality and safety and what we can all do together. And I'd like to put this in the context of the broader issues that we're really all linked together in trying to challenge. And I think this broader issue really can be put in the context of the challenges that every generation has to face. So in our particular case, I would say that every generation faces its own set of opportunities and its own unique challenges, and how it emerges from that intersection really determines its character and its impact and its legacy. And in our case, all of you around the room, especially those of you who are in academic centers, for example, know that we've seen remarkable opportunity. We are the genomic generation, we are the globalization generation, we're the computer and internet generation, and we have seen just mind-blowing advances in terms of biomedical research and science, whether it's anything from HIV to our cancer therapies, stroke, heart, just you name it, the advances are remarkable. But in terms of translating these advances into better lives and better health for everyone, how have we done there? Not so well. Not so well, and too many people are still making very difficult decisions about their health versus other aspects of their life. And these are the challenges that I think really could define our legacy if we let them, but of course we won't, and we can't. And that's really the fundamental motivation that I had in writing the book, The Long Fix, because I think that what's particularly challenging about healthcare, especially in this country, but many of these problems are shared around the world, is that the problem is not that we're not spending enough money. In fact, the problem is that we are spending too much money. And so if we look, for example, at this slide, which many of you are familiar with these data, this really presents this paradox that is, I would say, particularly uniquely American in this case. And here we're seeing, comparing the US with other high-income nations around the world, the fact that we are outliers in 2 dimensions. So we're both lower and to the right. So first, we spend far more money on healthcare per person on the horizontal axis as other high-income nations, 2 to 3 times as much. And just put that in absolute dollar amounts, that's actually a huge amount of money. That's about $2 trillion difference for the US, $2 trillion. And then what's of course even more remarkable and really puzzling is the fact that we have worse outcomes compared to all of our peer nations. And here, you know, the ultimate measure of health, how long we live and when we die. And in the US, we die on average 4, 5, or 6 years earlier than our counterparts in Italy or in Switzerland or Japan or in Israel. And of course, by other measures, the data are very similar. More of our babies die, more of our mothers die during childbirth, and so on. And so how can that be? And actually even extending beyond that, I think for those of us in this quality and safety space, you know, we've been responding to this kind of data. You know, this was Martin Carey's paper at BMJ that got so much attention a few years ago, suggesting that if you look at medical errors, it totals up to 1/3 only to cancer and to heart disease in terms of being a leading cause of death. And of course, very difficult to quantify, very controversial how this is measured, but nonetheless really shines a light on the challenges that we're facing in our healthcare system. And so these are the problems that I have been really incredibly curious about and very motivated to think about. And my journey to try to answer these questions started in New York City, where I was the chief scientific officer at NYU. My roots are in research. You know, I ran a NIH-funded lab for many years. But it was there that while I was running the lab and leading the research enterprise there, that I came to appreciate that healthcare's problems maybe weren't so much in research as they were in outside of research. And actually many of the problems were problems that other businesses had actually already solved. And so I went to business school on the weekends at the Stern School, and it became clear that it was really the business of healthcare that was falling far short, and we had a lot to learn. So unexpectedly, actually, I was then drawn to one of the parts of the country with the highest performing healthcare systems in the nation, and actually the healthiest state in the nation, the state of Utah. And there I was privileged to lead the University of Utah, which was actually the year I was being recruited was ranked #1 among all university hospitals. And together with the Mayo Clinic has actually been in the top 10 with Vizient for the last decade. And so there, not only did I have the experience of really thinking about population health, but also I served as a major employer and had that perspective of how can we actually reduce our employee health costs and improve their health outcomes. And then finally, after studying and learning not only from our own firsthand experiences in Utah, but also lessons from across the country, had the opportunity to write the book, The Long Fix. And when I was thinking of going on to lead another healthcare system, actually was already had pretty much packed up our bags, ready to go. The folks at Verily reached back again and said, you know, how can we think about using technology to really take some of these lessons from The Long Fix, for example, and really implement at scale? And so I've been there now for 3 years to build health platforms. And we now actually have 5 lines of business that are really focused on the triple or actually the quadruple aim: better health, lower cost, more access, better experience for all. So it's really from these different perspectives that I'm going to talk about what you've asked a challenge today, which is how do we think about quality, safety, and really engaging. In particular, I was asked to talk about engaging physicians. And so this is the perspective that I'm going to talk about. Now, when everyone talks about the costs of healthcare and outcomes, and we sort of study it and noodle it a lot, I would say that from all of the thinking, the actual secret of lower costs is really pretty simple, at least I'd say for this country right now. And it's just simply achieving better health. So while a lot of the narrative in the country is around costs, I want to just congratulate you for focusing today on really thinking about quality and health outcomes, because that's really where our focus has to be. And while we in healthcare naturally focus on what happens in the hospitals and clinics, of course, that's what I used to teach medical students, and that's really what we all focus on. I do want to remind everyone that while these numbers are, I don't think they're necessarily particularly accurate scientifically to the next decimal point, but they do convey the overall point that, and I think we've seen it really during COVID, that the vast majority of what determines a person's health is actually outside of what we do with them. And it really has to do with their own health behaviors and, of course, socioeconomic factors. And so that leads me to want to make a point, especially given that I was asked to focus on the physician perspective, to say that I think it is increasingly critical that we really think about our relationship with patients and how we work with patients to co-produce health. And this idea actually was one that was published a long time ago, first by an economist at Stanford, Victor Fuchs, and then it was published more recently, some of these ideas in maybe just a few years back by the Bataldens, Marin and Paul Batalden. And the idea is, how do we actually think about patients not as consumers, but really as prosumers? And the fact that in every other industry, we've already seen this transformation, but I think we're the last in healthcare. So for example, if you think about banking, in the old days, bankers did everything for us. I don't know if you guys remember those days, but you had to go in and work with the teller to deposit money and withdraw money, and you had to even go to the bank to figure out how much money you had in your bank account. That's why we used to, keep those balances in our checkbooks. And now that we're pros at banking, we're prosumers, we use ATMs, we use online banking. There's a whole industry of fintech that's ready to issue us a loan in like 5 minutes if we want one. And if you think about the lessons across the rest of our lives, I think it would be very valuable to think about how we are really, or should be, prosumers of health. And then what is our relationship as clinicians in thinking about it that way. And I'm going to introduce this as a concept, and then I will really dive more deeply into the hospital setting, but I want to create this as a framework. And I want to start by just illustrating maybe where I see this idea of co-producing health really taking off in healthcare, kind of the leading edge of it. And I'd say the leading edge of it is really in digital health solutions now. We are seeing these really proliferate, especially, they already were before COVID, but now everybody's really aware of them. And I think there are just dozens starting every day. I'm curious about how many of you are familiar with these. If we were in a room together, I would ask for a show of hands. How many of you actually tried any of these and other digital health solutions? Because if you haven't, I really think you should. When I speak with medical students and residents and fellows, I say in a very short while, you will be prescribing these. And in some parts of the world, actually, physicians are already regularly prescribing these, and these are regularly reimbursed. And if you look at all of these, I think if you sort of take them all together, there is a common theme. So I'll just show you very quickly 3 examples of how these work and how they lead to this co-production. And hopefully this will tie back together through the course of this presentation. So first, this is a company called Pivot. This was actually started by a classmate of mine from Harvard Medical School, who was an ENT surgeon out in the Bay Area at Stanford. And he just got tired of operating, all these tragic head and neck cancers, which he knew most of them were preventable. And so he decided to create this startup. And this is a smoking cessation program that includes this little black device, which is a carbon monoxide monitor. So the individual who's trying to quit smoking blows into it, and it approximates their carbon monoxide load. And so it gives them some feedback, gives you that red, green, yellow scale. And then of course, with the app, there's a lot of coaching. There's kind of ways to nudge people into first reducing the amount of smoking, and then trying, for example, to hit that first 24 hours without smoking. So this is one example. Another example, this is a company that actually I'm responsible for within Verily. This is one of our health platforms on Duo. It started in the diabetes space. It now is expanded to hypertension, weight loss, mental well-being, and so on. It's a lot like others in the market as well, so I'm just using it as an example. Again, here there's a device, a continuous glucose monitor, that enables, again, same idea, the patient or the individual to track their blood sugars 24/7. In this case, because there's a phone, you can take pictures of your meals and snacks, and individuals can make this association between how they're eating, sleeping, exercising, and what's it actually doing to their blood sugars. And then, of course, there's again, a relationship with a coach or a physician. A lot of AI, other things, but you can sort of start to see a theme for how these are working. And then third example is one called Thrive, which is Arianna Huffington's company, again, working with large employers, including Walmart. Here, it's really about overall well-being, wellness, a lot of micro nudges, a lot of use of social relationships to address everything from physical, mental well-being, even to financial well-being, for example. So just three examples. And when you put them all together, I think they fall into this rubric of collect, organize, and activate. They collect information, sometimes new sources of information like the sensors or new information that people might enter into their phones, for example, or their apps. It organizes the information into actionable steps. And then really the biggest piece of it is it really activates people. It's really about engaging people in behavior change. So I think we're seeing now the incredibly powerful lessons from the rest of the technology sector finally being channeled into what I hope will be very positive change, really positive forces for change in human health. And I think they are great examples of how we are thinking about this co-production, how clinicians can think about these digital health solutions as their extenders outside of the four walls in the clinics to the other 99.9% of people's lives outside of their site in terms of really engaging people in health and wellness in the ambulatory and wellness space. So now I want to move, now this is the outline of what I was hoping to cover today. I'm going to move more now into probably the space that you all expected me to talk about, which is acute care, the hospital setting, the clinic setting, and then pull back again into a more population health perspective. So I hope this is helpful. So now let's talk about this idea of how we can drive value, better quality and outcomes, and also at lower costs in the hospital setting. And in particular, I'm going to focus on the physician view, but I will, of course, bring in that the patient perspective as well, because I think that is a part of our narrative. It should be a part of our narrative always. So when we think about this within the hospital setting, this kind of slide is very familiar to everyone. We define moving to value, real focus on quality and safety, also the experience, and then of course, can we do this all at reasonable costs? And I'd say that this is really one of the hardest pieces of the healthcare ecosystem, is to change what is happening in our hospitals and clinics. Of all the areas, whether it's population health, patient behavior, or clinical behavior, I think we're the slowest. So just want to say the secret of change is to focus all of our energy, not on fighting the old, but on building the new. And in particular, I take a page from the change management lessons from business school, the standard algorithms for how we lead change, and recognize that many of you on this call are really trying to do exactly this. You're trying to lead change. So what is the algorithm that you're following in order to bring all of your teams and staff with you? So of course, communicating, developing your teams, establishing metrics. I'm going to particularly focus on data and the use of data to engage and empower the front lines through this journey to change. And that's really going to be my focus. And I'm going to start with an example or a lesson, and I think it's particularly fitting for a talk to the MGH crowd. So recognizing that not everyone on the call is necessarily from the MGH, as Dr. Kafarani told me, but I think many of you would have heard this name. Amory Codman is a very famous alum or graduate of Harvard Medical School and former faculty member at the Mass General. He came of age of the turn of the last century as a surgeon in the early 1900s. And that was a generation of many firsts in surgery. And so Codman's name is associated with a lot of eponyms, Codman's bursa, Codman's triangle, a lot around the shoulder, for example, but he did a lot of other firsts as well. Really interesting character. What was particularly interesting about Codman was his obsession with data and what he called the end results. He kept a card in his pocket for each patient that he saw back then, which he called his end results card. And on each card for each patient, he described what he found when they first showed up in his clinic, what he found in the operating room if he took them there, post-operatively what happened, and then 1 year later, what he found. And he was obsessive about this. He didn't just do this in the hospital, he did this in all other dimensions of his life, so it was something that he was obsessed with generally. But he really believed that we needed to learn from our experiences. And even to this day, more than 100 years later, I'd say that we are falling short. We still haven't met the Codman level of expectation in terms of learning from our patients. He also believed that physicians should be judged based on their end results. They should be posted publicly, and patients should look at end results when they decide where to be seen. And the most controversially, he actually thought that end results should determine the hiring and promotion of faculty and the naming of the surgeon in chief, for example. That put him in direct conflict with many of his peers, as you might imagine at the time. He was not the most, the EQ, IQ thing might have been a challenge for him. So he managed to offend, I think, most of his colleagues there, because he would often say, if so-and-so had their end results, they wouldn't be half as good as they think they are, which is probably true, but maybe not what he should have been saying to them. So there are some interesting lessons from Codman about how we should be collecting data and learning from it, but also lessons on maybe how not to lead change. Because in the end, he had to leave the Mass General. He stepped down and set up his own hospital, and maybe didn't see the impact that he probably deserved to see. If you think about how we today are operating in this idea of having a learning health system, and if you think about that same collect, organize, activate mode, how are we as physicians actually growing and learning and getting better? Well, I'd say that our tools right now are pretty limited. That in contrast to the digital health space, here we're really left with EHR, EHR, and EHR. We have very limited tools for learning how to get better. And so I think that there's opportunities there, and there's also opportunities for thinking about how do we really engage other clinicians, physicians, nurses, pharmacists, everybody on our team in this journey to learn and improve. So what lessons can we learn from Codman in that respect as well? And here I call on Daniel Pink's book, Drive. I don't know how many of you have seen this book. Ordinarily, I would ask for a show of hands. I'm curious if any of you have read this. It's not about healthcare specifically. It's about how do we motivate people. I picked up the book because there's a whole part about how do you motivate teenagers, something I was very interested in at the time. So what he talks about is the difference between extrinsic motivation and intrinsic motivation. And fundamentally, the idea is that if you are trying to motivate people who have very complex tasks, complex problems that they are trying to solve, which I would argue is most of what we're doing in healthcare, then the most rewarding approach is to try to tap into people's intrinsic motivation, to get that alignment so that what we want people to do and what they are intrinsically motivated to do is aligned. And I would argue that across healthcare, especially with our physician population, in the quality and safety space, we are really not well aligned. We have not absorbed this basic idea. So this is why I want to spend a moment talking about it. And what he talks about, he breaks down, and he's really deriving from a lot of psychology literature, so I don't want to give him all the credit. Of course, this is built on a lot of other work, is these three circles that I have here, that you want alignment around the person's sense of purpose, autonomy, and mastery. So purpose is easy because we are all fundamentally in healthcare, hopefully with the idea of trying to improve health. So I think that's not so difficult for us. But where we're falling short is the autonomy and the mastery pieces. So with autonomy, the idea is that you really want to give people the autonomy to feel that they have some discretion in how decisions are being made, in how they are being able to use their own capacity to act. And here, I think that this is a very important idea in healthcare, which is that it's not all cookbook. We are not all robots or widgets in the factory. We actually celebrate and value our own autonomy. And then in particular, we also have a huge amount of satisfaction in mastery. And I would say in healthcare, we actually even like to outmaster others, that actually there's a very strong competitive drive in particular layered on top of that mastery. So here's an example when you say, okay, this sounds great, it sounds a little bit abstract. What does this actually mean when you try to put it into practice? So I'll show you an example, I think, of how it worked. This is a case from when I was back at the University of Utah. And this is work from a group of our orthopedic surgeons who were getting frustrated with our quality metrics. Actually, most of our surgeons were frustrated. Actually, most of our physicians, let me just say, were frustrated with a lot of the quality metrics, and felt that these were kind of lowest common denominator. And so we said, okay, fine, you're not happy with them. Tell us what you think. Use your autonomy, tell us what you think ought to be in our definition of perfect care. So the orthopedic surgeons, in this case, I'm showing you the scorecard that they created for the total hip and knee replacement patients. And their definition of perfect care, actually, they came up with the name perfect care. And you'll see that some of these skip PSIs, they're standard. We had to include them because we still needed to get paid. But they added the top two. They added early mobility on the day of surgery. These patients getting hip and knee replacements should ambulate on the day of surgery. And they also added admit to the orthopedic trauma surgery service because they had evidence there also that patients who are cared for by the specialist teams did better than if they overflowed to general surgery, which was actually happening quite a lot back then. So we now adopted this perfect care index, and we discovered, for example, that many of our patients were not ambulating on the day of surgery. We had not been tracking it because we weren't getting paid for it. It wasn't in our EHR. But when we tracked it, we realized that the cases who were coming to the floor late in the day, physical therapists had already gone home, so they weren't able to ambulate. So this was a very easy problem for us to solve. We just shift some physical therapists to later in the day. As a result of this new definition of perfect care, we really had great physician buy-in because it was their measure. And over time, we saw significant reductions in length of stay and in costs of care, about 11% savings, and which fell to our bottom line because these are DRG-based payments, and really significant improvements in outcomes. And these were published actually in an article in JAMA. Now, what we called perfect care, others had slightly different names. So Geisinger called it proven care. And in Mayo, they call everyone expert. So they call it Ask Mayo Expert, for example. But it's the exact same idea. In these other enterprises, they actually had the physicians engage in defining how should care be delivered, what perfect care, proven care, or whatever is optimal. And I would say, is a reason why these systems have had consistently extraordinary results in terms of better outcomes for their patients and higher on quality and safety measures. So you need motivated physician leadership. And the same lessons apply to cost of care. So if you take this lesson and you just generalize, I'd say I'm going to share with you a very short story, but the same idea around trying to tackle costs. So when it comes to costs, we don't have as many measures generally as we do in quality. And in fact, back when I first started at the University of Utah, it turns out that we did not really have information about the costs of care for each physician and clinician about their patients. We had costs overall. I could tell you our overall labor spend, our overall pharmacy spend, even maybe a service line, but the actionable level, did I know what Dr. Kafarani's actual individual patients cost? No. Did I know what Dr. Lee's patients cost? No, I didn't know that. So we actually worked to begin with to actually work out what the cost of care were for every physician. And I'm not talking about what we build. I'm actually saying, how much did it cost us to provide that high quality care? And some of it was very straightforward, just allocating supplies. Other bits of it were a little bit more complicated. So here's an example for an appendectomy. We worked out what did it cost in the ER and the OR, surgical ICU, step down units, whether it was labor, imaging costs, pharmacy costs, lab costs. And believe it or not, all of the data are in your systems. It's all there. It just hasn't been put together in a way, in my view, it's that collect, organize, activate. It's been collected. It's not necessarily organized in a way that's actionable. We did this. It was not that complicated, and you won't be surprised to hear that we're working on this also in Verily. And basically, once we started doing it, we saw data like this, that for every procedure, in this case, this is DRG 470, total major joint replacement, it's hips, knees, and ankles. And here are all our orthopedic surgeons at the University of Utah at the time. And we just saw this huge variability in cost. Some of it is because of the patients. There are a couple of physicians here who do ankles. But even when the patients are pretty consistent, you just see an enormous amount of variation. And that's probably consistent with what you know and your daily lives in practice. So in reducing the variation, we're not only thinking about it in terms of quality, but once we drive the quality, we also see a reduction in variation in the costs, in my experience. And because we're paid on an inpatient basis by DRGs and these prospective payments, if we're able to reduce the cost, for example, for a total hip or total knee or a pneumonia or a heart failure admission or pretty much anything, those dollar savings really fall to our bottom line. So what I'm showing you here on this slide is the fact that by improving value, we really improve the business. In gray are the operating margins for nonprofit health systems across the country. In purple were the dollars for the University of Utah. I inherited a system that had about a 4% margin, and through these value initiatives, we were able to more than double our margin, which of course was incredibly valuable for funding research and education. And then of course, managing to really drive the quality, being kind of the primary force there. So these kinds of opportunities, I think if we put them in the context of the collect, organize, and activate, and thinking about how do we co-produce with patients, has brought us at Verily now to building out these tools that we call the Value Suite with the same idea in mind. So how do we identify opportunities across a health system that show the variations in quality and outcomes and the variations in cost? And then how do we make those tools accessible to the physicians and the care provider engine, and then bring the patients along? So if you can imagine what I've just shown you already, with an additional layer of the digital health patient engagement co-production model, that we can actually envision, for example, let's say we are working on reducing readmissions for some surgical procedures. You have the opportunity to overall, you have the data already in your system to see where is there maybe unwarranted variation, whether it's in our prescribing patterns, in our use of devices in the operating room, whatever it is. How do we provide the insights at the level of the physician? And then we actually, even before they come in, the patients actually already get their perioperative, preoperative workup and evaluation and education on their apps. And then when they go home, they have all that educational material that you've provided to them, usually at times when they're not very well equipped to absorb it, but now they have it in their apps or on their devices, as well as those sensors and other monitors that can enable them to care for themselves outside of the hospital and reduce those readmissions. So bringing it all together makes it an effort at co-production that is really data-driven. Again, an extension of the model that I showed you in digital health, but now really acting at the acute care and post-acute care space. So I hope that's a good amount of food for thought there. And let me just finish. I'm going to finish with, I probably should have just finished there, but I'm going to finish with one quick vignette to put us now in the population health space. And I can't resist doing this because I feel like so much of the time we are working in hospitals and clinics and kind of day to day, and we forget sometimes who's actually paying us and how we're accountable to them. So I'm going to finish with a broader view of population health. And this is a case study, and I'm going to read a short section from my book in the last few minutes that we have here. And this is I hope you'll understand why I've included this after I do this reading. This is a section called Let's Poke the Skunk. And it's, well, I think it's self-explanatory. Let me start. In December 2004, Bob Mecklenburg received a visit that pretty much ruined his Christmas break. Mecklenburg was chief of medicine at Virginia Mason Medical Center. His hospital was paid to provide health care to employees of 4 of Seattle's biggest companies and employers: Costco, Starbucks, Nordstrom, and King County. In his office that day was the medical director of Aetna, the third-party administrator for each of the 4 self-insured employers. He told Mecklenburg that the care provided by his hospital was too expensive and that unless something changed, they would dump Virginia Mason. Mecklenburg, who was responsible for hundreds of millions of dollars in his department's annual budget, most of which was clinical revenue from caring for patients, had a startling realization. I'd never come face to face with people who paid my salary. I thought Virginia Mason paid, but it was these employers. He goes on to talk about what he called kitchen table research, where he got all the data from those employers, all the claims data, and he worked out, it wasn't very easy because, for example, just back pain had like 12 different names: sciatica, backache, etc. Anyway, he spent a lot of time pulling together all the data about what was driving up those costs for those employers out of Virginia Mason. And he learned that it wasn't just those rare patients with cancer, like you might think, or those infusions, for autoimmune diseases, but it was actually really common illnesses that were being cared for in ways that maybe weren't totally evidence-based. And it was what he called yestercare, over-treatment, over-diagnosis generally. And when I asked him why everybody didn't seem to have these insights that he had, or didn't seem to push for change, he said, they like it fine the way it is, fee for service, why mess with it? We're making billions of dollars, why poke the skunk? Now, what he then realized was that he was really grappling with a business problem. I'll just read this part, not a medical one. And that his HR partners were extremely well equipped to help him solve it. He explained to them that they had a, quote, supply chain issue, a clinic failing to keep an employee from getting ill and missing work was the equivalent of a chip manufacturer delivering a poor quality part to Intel. Think of it this way: if employees are homesick, Nordstrom can't sell clothes, and Costco can't restock shelves. Using that fundamental insight, the 4 Seattle companies drew up 5 key performance specs that Virginia Mason Medical Center would have to meet. So they're treating us like a supplier, like any other supplier, which is an interesting framework. So here are the 5. What? Give us what works and skip the rest. Evidence-based medicine. Number 2, 100% customer satisfaction. Okay, what else would you expect from Nordstrom? 3, same day care. Okay, there's an issue, we want to be same day, Starbucks said, you wouldn't expect to order a tall skinny latte and say, oh yeah, it'll come in 2 to 4 weeks, Number 4, this is actually one of my favorite, rapid return to function. Rapid return to function. But we've never been held accountable for rapid return to function in all our days. And yet, if you think about it from the perspective of the people who are paying for us to do our work, it's not surprising. That should be one of our top expectations. And then number 5, predictable and consistent prices for buyer and seller. Now, many of you who have followed the Virginia Mason story know that, and I talk about, an example of how they worked on back pain, for example, in spine surgery, but you'll know that it was their success in doing this that really led them to become a center of excellence for these large employers, including Walmart and Lowe's and others. And so if we take the lessons from that, we know that they need better data, that from the better data that they can really focus on the 5% of employees that lead to that healthcare spend and can really focus on the areas that they need to focus on, including prevention and screening. And that as part of my, that chapter is a chapter for employers, and I have these 10-point action plan recommendations. And one of them is that employers really should partner with health systems in their communities. And so I'll say that to you all, that you should be partnering with the large employers in your area, because you, not only are they your major customers, but also they actually have a lot that they could teach us. We went through a whole lean initiative years back. Actually, we did it in New York, and then we did it again in Utah. And of course, these folks, you know, one of my board members was a manufacturer CEO, and they know about many of these things much better than we do, and they can help us. And then finally, of course, we're actually working with them to integrate these digital health solutions, because they're the ones that actually ultimately will be paying for most of those programs. So partnering with your employer population, your communities, I think is a very, very important part in driving quality overall. Okay, so with that, I will wrap here, and I'm very happy to turn it back over to Haitham to run the Q&A, and hope we've shared some good food for thought. So looking forward to the discussion.
Well, thank you, Dr. Lee. I won't be exaggerating if I say this is probably one of the best talks I've listened to related to quality and safety, in terms of putting the fingers on the spots that really we are all struggling with. And I have plenty of questions, and I encourage everybody to put their questions in the chat, and I will try to go through as many of them as I can. So one of the things that I'm going to poke the skunk, I guess, but one of the things I struggle with now is we created really very good medical record systems, electronic health record systems. But you know, every system delivers exactly what it was supposed to deliver, and a lot of them are tailored to the billing, to optimizing billing, to make sure everything is there. And the problem is, when we try to use these same electronic health record systems with all the data they can provide, the wealth of data they are, to answer quality and safety questions, or even research questions for that matter, it becomes very cumbersome and not as reliable. And I was wondering if you can share with us some of your thoughts on this topic. How do you think this can be solved? Besides recreating electronic health record system, what can we do?
So that is a fundamentally important question, because what we learned when I was at the University of Utah was that we actually have a lot of valuable information in the EHR that we can start with, recognizing that a lot of it is garbage in, garbage out, as you're saying, right? It's used for billing. We click, we cut and paste, and you know, so on and so forth. I think everybody knows what I'm talking about there. But if we start to extract what can be used, so for example, we were able to work on the standard quality measures and also the cost data that I showed you. And once we started providing feedback, once our EHR became a lending library, not a museum, and what I mean by that is not just stuff you put in there and you never see it come back to help you in any way, but in this case, actually come back and actually provide useful feedback, we actually saw the quality of the data going in improve as well. Oh, you're actually using these data. Oh, actually, I'm seeing these data on my own individual quality dashboards. So we actually saw that improve. And I think it's a challenge for every organization to reverse that decline and to sort of start to pull ourselves out to say, oh, actually, these EHR data can be really valuable. So starting where the data are the most accessible and probably the most actionable is that's the reason why the value suite work that we are doing in Verily is really laser focused on, from a business perspective, the most important pieces of data right now. What's driving your quality scores, and then what's driving your overall cost of care. And of course, a lot of the quality measures also impact the financial picture as well. And starting there, and then over time, looking for improvements in the data, in order to drive some of the other changes. But I think right now it's very important to make these investments, because you really, especially in training hospitals, where you really want the next generations of physicians to think about the EHR as a really valuable resource, and not simply as a burden. And of course, the EHR vendors are also working very hard, to try to obviously make that happen as well. So between the EHR vendors and other parties, including our own, I think we'll start to see a reverse of that. You know, I think the worst days are behind us.
I certainly hope so. I certainly hope so.
I hope so.
We got a few questions here. I'm going to just go them chronologically as they appear. So first one is, are you using TDABC accounting methodology? And is your hospital collecting information to allow this method? Or hospital has accounting practices which make it difficult to look at the individual cases in terms of cost? And that's from John Werner.
Right. So for those of you who are not cost accounting experts, I'll translate the question for you a little bit. So when we look at the actual costs of care, so the slides that I showed you about working out how much does it cost to do a hip replacement, not what are we going to bill, but this is, again, what does it cost us to deliver the service? And just to take let's just take one moment to step back and recognize that in healthcare, we're one of the only businesses, I would say, in the world where we don't routinely know our costs, right? If you go into any car manufacturing plant and say, okay, how much does it cost for you to build that, you know, Subaru or whatever it is, they're going to tell you exactly what it costs, what the markup is, and then what they're selling it for. We're one of these businesses where we really don't know our costs at the individual, you know, when we provide the care. So just take a moment to let that soak in, because it's sort of a realization. Now, so let's say we want to fix that and we want to actually know what it costs, because if you're going to engage, for example, in a bundle, or even with DRG payments where the government says, okay, I'm going to give you like $15,000 going forward to do this operation, you really want to know what your costs are, and you want to know where there are excess costs, for example, or there's a lot of variation in the cost that you can reduce so that you won't go bankrupt in that bundle contract, right? That's the whole point that we're talking about here. Now, when it comes to cost accounting, what John Warner is asking is about something called time-driven activity-based costing, TDABC. And time-driven activity-based costing, I call it the stopwatch approach. So it's usually around this issue of figuring out the cost of labor, the cost of your physician time or your nursing time. And so TDABC, you use a stopwatch and you count, okay, physician in the room for 42 minutes, or went to see the patient for 10 minutes or whatever, and you add up the amount of time that they spent in order to work out the costs of that surgeon's time, for example, or the nurse's time. So after that long introduction, my answer is no, we do not use TDABC. So we don't use TDABC. We didn't use TDABC at the University of Utah, and we are also not using TDABC in Verily Value Suite either, because in our view, it is way too labor intense, and also because it doesn't allow for change. So TDABC, you do a stopwatch on, you know, what is it, May 27th, but you know, something changes in the next few months, and what are you going to do? You got to go back and stopwatch people if, you know, something changes in the way in which you're practicing. So we use a different approach that is, that I'm happy to talk more about. We actually published it in our JAMA article, if you want to read more about it. And there's also a JAMIA article where we wrote about this back in the old Utah days. So, and that is an approach that's more based on RVUs. So we have physician times in terms of dollars per RVU, and it just means, you know, you just click and you can kind of figure out physician labor costs in that way. It's much more scalable.
All right, that's awesome. We have quite a few more questions. Here's one that's still related. It's to the same topic, so we'll go through it and then we'll go to the other topics. Can you share some insights into changing physician behavior, especially surgeons, and alignment with the hospital when it comes to cost management?
Yeah, so one of the things that we did at the University of Utah is that we actually created a shared savings model. So because this whole project, by its very nature, we were measuring costs, right? So we could actually measure how much we saved by different behaviors. So for example, when the physicians implemented when we changed the physical therapist's schedule, or when we made some changes in terms of supply costs in the operating room, right? We discovered that the artificial hips, there was a threefold difference in cost, threefold. and no change in outcomes. Outcomes are all the same. So there were a lot of changes that took place in the orthopedic surgery department once we showed them the data. And we shared those, we meaning the main university administration shared those with the Department of Orthopedic Surgery. And the rules were that they couldn't use the money for compensation. Didn't think that would be a good idea to financially incentivize them to spend less, not a good idea, but they could use the money for discretion. So they hired MAs as scribes, they bought out their time, they went to meetings and presented a lot of this quality improvement work. That actually was really very significant in terms of buy-in, I think.
All right, well, here, follow-up question along the same lines, which is probably an argument that you've heard a few times, and I think it has value, to be honest. And that's coming from Nahal Elias. It says, would cost consciousness translate into risk aversion and avoidance of caring of complex population? MGH prides itself in caring for complex patients who are denied care elsewhere.
Well, I think that really brings up this very important question of risk adjustment, or how are we accounting for the complexity of patients? And it's not an easy task. You know, there are many risk adjustment algorithms that are out there. I think there's still room for improvement there. But clearly we have to take into account when people are caring for more complex patients, they will, by their very nature, likely lead to overall poorer outcomes than taking care of very simple patients. And they also are likely to be more expensive than caring for simpler patients. So that has to be reflected in the model. We can't use just one set of standards across all patients. I think that wouldn't be fair. And of course, it would exactly motivate what you're saying, people avoiding the complex patients in favor of the simple patients. And that's the last thing we want to do. And it would also lead to even wider, in my sense, wider health disparities, because people would obviously tend to avoid people who are underinsured or who haven't had enough preventative care, for example. And so we definitely don't want that to happen. So we are factoring in all of these models that we're doing, for example, in Verily, the risk adjustment. That's absolutely critical.
I have to just take a moment to add my voice to yours. I'm very passionate about that specific answer you gave. And my answer typically is, you know, this is not an excuse to not measure. I mean, we have to put a lot of focus on risk adjustment, and that's really at the core of quality. And I do think that's the area with most opportunity to improve in the future, to gain engagement of the frontline clinicians and physicians. I'm going to switch gear to a very interesting question by Ray Liu. What will the impact of newer healthcare verticals like CVS, Aetna, Amazon, PillPack, United, Optum to be as a force in delivering higher quality and lower costs?
Well, they're different. These different examples are different. So it's a great question. What you're seeing here is in some cases, so Amazon PillPack is different from United Optum, which is also different from CVS Aetna. So it's hard to answer in one. But let's take Amazon PillPack. Amazon PillPack, you are seeing a company that is just top in class in terms of delivering care or delivering products and now services, you know, moving more into the service spaces to people when they need it, just, you know, with like lightning fast speed. And the operations, the logistics of it, and the transparency of the pricing are, you know, really distinct differentiators. So getting into the pharmaceutical industry, getting into PillPack, I think there's some that it's going to be very, very interesting to see that. CVS and Aetna is a PBM and a payer. United Optum is, I think what's remarkable about them is they're a payer that are really acquiring providers like there's no tomorrow. So there's kind of more both of those are really consolidation plays. And I would say that it's not clear. You know, it's not clear what the outcome is going to be. I have this debate with Mike Porter all the time. about consolidation, because when we were at the University of Utah, we decided to set up our own health insurance plan. We already had a little plan for our own employees and for Medicaid, and we took a commercial license and grew to about 250,000 lives by the time I left. It was very interesting because we were pretty good at bending the cost curve. And Mike said to me, I know you love this idea of an integrated payer provider, but this consolidation is going to have a negative impact on the market, right? It just means there's more market power concentrated in fewer organizations. Yeah. So I guess when you say, how will they be as a force for delivering high quality and lower costs? I would say if that's what they want to do, they will be an incredible force for higher quality and lower costs, because they have the data and they have the operating capability through their PBM pharmacy side or through their physician groups, for example, if that's their goal. If their goal is to make more money and drive and negotiate and get higher, just be a more powerful market force in order to drive profitability alone, maybe not so much. So it just depends on what they're trying to do it for.
Vivian, there's 3 amazing questions that probably all need 1 hour of response, but I'm going to ask you to answer each one in 1 minute so that we go through all of them, because I love all of them. Well, first one is by Evelyn Joseph. Noel, she says, how do you transform consumers into prosumers?
You create the tools. There's always education, but then you create the tools that empower them and that meet them where they are, what matters to them as consumers. That's what the consumer space does so well, thinks about what matters to the consumer and builds the product accordingly. We do that terribly in healthcare. But if we do it right, and I think the digital health people know how, we can do that.
All right. Yael Heher goes, lab testing costs are a large part of inpatient and ambulatory costs, but the incentives are complicated with regards to value and quality. Goals have included managing diagnostic error and also shepherding utilization. Do you have thoughts about the future and partnering with lab IT vendors like Beaker, Epic, etc. to guide change?
Yeah, this is actually a part of our value suite offering. So we've been thinking about this a lot, which is what are value added lab tests? And I can't do this in 1 minute, but I will say that the algorithms that we've developed to look at where have lab tests really changed outcomes, changed the trajectory of care for an individual. There's a lot of interesting insights that you can get from looking at the data on lab testing and trying to figure out how can we actually use lab testing in an appropriate way that drives the most value. And I think we're just in the infancy there.
If you thought 1 minute is crazy to answer that question, here's another one that's crazy to answer in 1 minute. What was the biggest cultural shift that needed to be made at the University of Utah to improve quality and value, in your opinion?
The culture was already one that embraced change. So I would say in most places, that's the biggest cultural shift, is the readiness to actually change. A lot of people don't think like change, oh yeah, you go first. Oh yeah, we saw this 20 years ago. I'll ride through until my retirement. I don't need to worry about this change. I'm just gonna, the culture there had already embraced that. And so then the next shift that I had to help steward was simply providing the leadership and the guidance for how to make that change as easy and sensible and rational as possible. And providing those data, as I showed you, and the processes and a little bit of incentive, a little bit of a reward. Don't make it hard, make the right thing the easy thing. That's kind of a good mantra, I think. That's what I had to contribute at that time.
All right, well, Dr. Lee, we're at 2 p.m. now. I want to be respectful of your time. Your insights have been fascinating for me, as have been for many, with a lot of complimentary comments in the Q&A session. So thank you so much. I'd also want to thank all the staff at Compass that made this webinar happen, as well as staff at Verily that helped us do this, but especially Olivia McKenzie, who's our program manager, and facilitated all of that. Thank you so much, Dr. Lee, and we look forward to seeing you more and more.
Thank you. Thanks, everybody. Wonderful to be with you.